All right, things are starting to calm down a little bit, so I will introduce to Dr. Nathan Ledeboer. I'll do the official introduction first. He is a professor-in-chief of clinical pathology in the Department of Pathology and Lab Medicine at the Medical College of Wisconsin and the Associate Chief Medical Laboratory Officer for Froedtert Health in Milwaukee. There's a lot of capital letters in there. His research endeavors, particularly in the area of developing diagnostic tools for infectious diseases, have led to numerous publications in peer-reviewed journals and more than 200 funded research projects. By his own admission, he is a bean counter from Milwaukee and truly does follow the Packers, not the Vikings. So with that, take it away, Nate.
Well, thanks, Al. I appreciate the introduction, and I have to admit that the capital letters were largely because for some reason, the slide template and I didn't agree with one another, and it wouldn't let me not capitalize things. So I'll blame PowerPoint on that one. For the purposes of the talk today, I am not going to use your slide clicker technology. I'm going to use the really old-fashioned technology, and that is I'm going to have a couple questions for you that I'm going to ask you to use your hands very briefly. So be prepared for that, and I think there's some interesting cases and some examples. So we've been spending a lot of time today talking about sepsis, and we've spent a lot of time really talking about how does microbiology impact sepsis. But if we take a look at kind of where we've gone and we look at the continuum of sepsis, we've started to see a lot of advancements that are starting to happen in front of the culture or in front of microbiology. But if we take a moment and take a historical look at where have we been with sepsis diagnostics, before the year 2000, or for many of you, before time began, we focused on blood cultures. We focused on how do we make blood cultures better? How do we improve them? How do we improve the sensitivity of blood cultures? For many of you, when time began, we started focusing on molecular testing and how does molecular testing impact the diagnostics that we do or the work that microbiology does. And by the early to mid-2000s, we started to see some early host response assays. The first really being procalcitonin that was intended to help us diagnose sepsis, diagnose pneumonia in a bit of a faster fashion. Since that time, we've seen introduction and in some cases departures of direct pathogen detection technologies. And we've also seen introduction of a number of host response assays really designed to help us identify who are the patients that are at risk of sepsis at the time they walk into our emergency room. And then be able to flag those patients for a more intensive level of care so that we can prevent them from going into septic shock. And I'm going to share with you some data today on some early trials evaluating some of these diagnostics and what some of the potential of them may be. But before we get into those trials, one of the key questions is take the perspective of the emergency room. 80% of sepsis patients will present to the emergency room. And one of the biggest challenges that we see with sepsis patients are identifying who is the sepsis patient out of the sea of the other patients that are waiting in the waiting room. And when we think about symptoms of sepsis, fever, hypotension, tachycardia, tachypnea, altered mentation, it's a fairly common and nondescript set of symptoms. It can be associated with things like cardiogenic shock, sepsis, pulmonary embolism, heart failure, as well as myocardial infarction. So how do we pick that needle out of the haystack and identify who is the septic patient and who isn't? Well, if we look at other time-sensitive medical emergencies, in the case of myocardial infarction, we have really good diagnostic technologies. We have tests like we have tests that we can offer. We have the EKG that we can do, all that help us to risk assess and determine, is this patient having an acute MI or are they not? Similarly, when a stroke patient comes in, we have good technologies like the CT scan that can help us to get to a diagnosis. But when we have a septic patient that shows up, yeah, I'm going to give you a blood culture. It'll be 3 or 4 days before I can give you an answer in some cases. Maybe I can give you a lactate that will tell you a little bit about hyperperfusion. We don't have good diagnostic tests that can help us get to the right answer. And as one of our earlier speakers pointed out this morning, for every hour that we delay empiric antibiotic therapy, we see an 8% increase in mortality in average data. So if we think about new sepsis diagnostic technologies and we think about what is sepsis, let's first take a look at what sepsis is not. So sepsis, first of all, is not infection. It is oftentimes precipitated by infection. But sepsis is really an uncontrolled immune response. So if we think about your normal day, I bet almost every one of you, and I won't ask for a show of hands in this case, every one of you brushed your teeth this morning when you got up. In my case, it was way too early when I got up to drive to the Dells. Well, I was probably briefly septic this morning when I brushed my teeth. But my immune system recognized the pathogens, it targeted them, and it got them under control. That happens for almost all of it, probably happened for all of us this morning. But when we look at the septic patient, you have an initial introduction of some kind of a pathogen, and then you begin to see dysregulated cellular immune response or over-response of the immune system. That patient is then beginning to develop sepsis. We then see the patient progress to shock if we don't get the infection under control, and with shock comes organ failure, and with organ failure comes death. So if we can identify who is at risk of infection earlier, we can prevent that patient from moving into septic shock, and we can move towards having our best outcome, which is ultimately the patient responds, and we get the dysregulated cellular response under control. Again, I want to emphasize to you that when we look at the group of patients that we suspect of having sepsis and have those very, very nondescript symptoms, and we take our very terrible tests that we currently have, we've got this big group of people that are suspected of having sepsis. Well, as we investigate these patients a bit more and we get to understand what is their presentation, what they may not have, we can narrow that down into the septic population. And then among the septic population, we can identify a certain number of them that will have bacteremia, and then a larger group that will have DNA-emia, where we can detect the presence of a pathogen by a molecular test, but we can't necessarily grow the pathogen because maybe we've pre-treated the patient. But our bacteremia patients are only one subset of our sepsis patients, and certainly we see bacteremic patients that aren't septic. Again, me probably this morning when I got up and brushed my teeth. So I think we'd all agree there is a need for better markers of infection status in our world. And just to give you a little bit of a sense of how broad and how unregulated the sepsis field is, I participated in a multi-center study a number of years back where we presented patient histories to a group of physicians. These included people that were laboratory medicine, emergency medicine, critical care physicians, ID physicians, as well as pharmacists. And we asked the group, when we gave them the same patient history data, what is the chance that this patient has sepsis? So I'm going to show you that data. I'm going to show you that question right now. So this is a patient presentation that we would expect to see. So this is a 72-year-old female who presents to the emergency room having been a nursing home resident. Her past medical history is significant for dementia, hypertension, and dyslipidemia. At baseline, she's mobile, lives in a skilled nursing facility. She's able to ambulate fairly relatively, and she's described as being pleasant and communicative. On the morning of presentation, she presents with altered mental status. She's difficult to arise, and she really can be arisen with physical stimuli. She's sent by the nursing home to the emergency room, and when she presents to the ED, she has a temperature reported of 97.8, her heart rate is 84, and her respiratory rate is 16. Her blood pressure is described at being 98/62, so a little low. And her oxygen saturation is 95% on room air. And again, in the emergency room, she presents as somnolent, responding only to physical stimulus. Some of the key laboratory findings on her is her white blood cell count is reported at 9.8. She has a lactate of 2.8. Her creatinine is 1.9, which is elevated over her baseline. And on UA, her urine is reported to be positive for nitrites, bacteria, and white blood cells. This is the information you would typically get at triage as a triage nurse or as an emergency room physician. So now I'm going to ask you guys to get those really old voting machines out. How many of you think this patient has a less than 25% chance of being septic? Got a couple in the back. How many of you think there's a 50% chance of this patient being septic? So a lot of you guys are the coin flippers. How many of you guys think that this is a greater than 75% chance this patient is septic? Wow. We're fairly concentrated into the middle. When we asked our group of participants, again, comprising experts in this field, using the exact same patient histories, what is the chance of this patient having sepsis? Our experts, you'll see where all of our experts voted over here. And our votes range from less than 10% chance of the patient being septic to 100% chance of the patient being septic. And our group split right down the middle with this group at a 50-50 chance of this patient being septic. So anytime somebody makes the argument to you, we're really good at identifying sepsis patients, I'd argue to you the data says, at least based on the information we have, we're actually not very good. And these are experts. These are faculty at academic institutions that supposedly are the thought leaders of the institution, and they can't pick out a septic patient the same way. I would argue to you today that this is the strongest argument that we need better testing technologies to help us make a determination who's at risk of sepsis, who is the person that needs higher levels of care, and who shouldn't have higher levels of care, or who may benefit from more of a wait and see approach. So over the last 15 years, where has technology taken us? Well, we've seen, and throughout the presentations today, we've seen a ton of examples of where technologies have had great benefits into the inpatient environment. In the inpatient environment, we've had technologies like the Verigene. We heard an example of that this morning. We've had technologies like the BioFire that are able to get identification and rapid susceptibility information back to our clinical teams in a much faster fashion. The downsides of these technologies are they've entirely depended upon a positive culture, which again is 2 to 3 days after that patient has left the emergency room. We've seen introduction of technologies like the T2 Biosystems technology, which both came and left us in the last couple of years, that ultimately haven't succeeded because of their complexity and their cost. Similarly, with rapid AST, there's a lot of promise, but this has been really slow to move into the clinical environment. So we've seen improvements in detection of infection or those agents that are precipitating sepsis. When we look at measuring sepsis progression, again, in the inpatient where we're trying to follow patients, are they improving? What are their organ systems doing? We have decent tests. We have tests like lactate. We have the SOFA score to help us assess severity of sepsis in the ICU. We have tests like CMP that allows us to look at individual organ systems and assess how organ systems are progressing. But when it comes to identifying who's undergoing that dysregulated immune response, we don't have a lot. We've got the SIRS criteria. We could have an entire hour debate on whether the SIRS criteria are good or not. I would argue most clinicians would say they're not. And then we have that clinical gestalt. And you guys just saw a moment ago, when I give you the same history, our clinical gestalt isn't all that consistent from individual physician to physician. So if we look at what are the existing sepsis biomarkers, we really can see them fit into three different categories. Procalcitonin is a marker of severe known bacterial infection. It's been FDA cleared for use in sepsis patients as well as pneumonia patients, and its rule-out performance for sepsis is 56 to 93%, depending upon the study that you cite. Lactate is a little better. It's fast, but it measures hypoperfusion. So it detects lactic acidosis or tissue hypoxia. Its rule-out performance for sepsis is about 80%. And then we have the blood culture. It's a test to measure bacteremia. It allows us to initiate definitive therapy, but the turnaround is pretty bad on it, 24 to 48 hours. And the rule out for sepsis after that 48 hours, or in many cases a 5-day incubation, is around 78%. So there's some opportunity for improvement there. We've seen development of a number of new sepsis biomarkers technologies that I'll classify into three different groups. And I'm going to show you examples today from each of those different groups. I'm going to also share with you a little bit of outcome data from each of those groups. The first group of tests, one of them is known as the trivarity tests, are the transcriptomic tests. These are tests that look at cell signals or RNA signals coming off of your cells in response to that infection being present. These tests are generally performed with molecular technology, instruments like the BioFire instrument, and the advantage of them are they're fairly simple to run. They can be done in the point of care. But these guys are expensive. These guys are going to cost you anywhere from $200 to $500 a test. Second group of tests are tests that I'll call our physical measurements. They measure physical properties of white blood cells. These tests are a little bit cheaper, around the $100 range. They can be done relatively quickly. And the third group of tests are the AI tools. And interestingly, on my ride over here today, as Dr. Wood was driving me here, thank you, Dr. Wood, I had a chance to read an article on my phone from an interview from the CEO of Palantir. Palantir is one of the leading developers of AI tools. He is saying that unless you are in a trade or you have a different way of thinking or analyzing data, your job is going to be eliminated by AI. I don't know if I believe that entirely or not, but we have certainly seen proliferation of AI tools. And sepsis is just one of those areas that we've seen proliferation of these tools, and we'll talk about a couple of examples of where AI tools can be layered onto existing data in order to help us flag sepsis patients a bit faster. But let's take a little bit of a look at each of these technologies, as well as some of the outcome data where it's available. So the host response diagnostics, as I mentioned, we can classify them into two different groups: those that look at physical properties of the cell and those that look at gene expression. Our two examples that are gene expression-based tests are the trivarity test and the septisite test. Both of these are FDA cleared and have an FDA clearance for either bacterial, viral, or ICU level of care, or detection of sepsis in the case of the septisite test. The performance is relatively good on these technologies, around a 91% negative predictive value or ability to rule out sepsis. And these are and the trivarity is cleared for use in the ED. The septisite is cleared for use in the inpatient or the ICU environment. Our biophysical tests The examples would be the MDW test as well as the IntelliSept test. These measure either sepsis or immune dysregulation. These can be done really fast, 8 minutes or a minute, depending upon the test, and have fairly high negative predictive values. Both are cleared for use in the emergency room. So at Freighter, we did about an 18-month pilot with the IntelliSept test in our emergency room, taking a look at what is the impact of the IntelliSept test if we use it in routine care for patients that are presenting with suspicion of infection. So the test works. Let's see if my video will work here. It does. The test works by measuring cell elongation. So on the top panel, you'll see a normal white blood cell traveling across your screen, and you see that it's nice and compact and together. By contrast, the white blood cell from a septic patient elongates out almost a bit like a parasite looks. The test measures these properties under hydrodynamic force, and if you see enough elongation over a large population, that patient is then assigned to the risk of sepsis population. Now, the good thing is the lab doesn't actually have to do any of these measurements. The instrument takes care of it and does about 1,000 of these measurements before rendering a final result. And the instrument then will assign, based on the number of cells that elongate in the population, a risk of sepsis. And it assigns patients into a band 1, 2, or 3, making it fairly simple even for relatively dumb folks like myself. Band 1 are those low-risk patients. I'm hoping all of you, if we tested you today, would be in the low-risk population. Band 3s are high risk. These are patients that are at risk of severe immune dysregulation or are significantly at risk of sepsis. And Band 2, because these patients all present in a somewhat continuum, are kind of those patients that we don't really know what to do with. They're the patients that we need to take a wait-and-see approach or kind of follow those patients a bit closer. We can, in many cases, based on the negative predictive value, feel very confident in ruling out sepsis in our Band 1 patients, and we can feel fairly confident that our patients in Band 3 have a higher positive predictive value or have a higher chance of being septic. So we set out to utilize this test at Freighter Hospital in our emergency room. So we initially launched the test and we basically said, clinicians, here you go, use the test. We did a fair amount of education to our clinicians on what the test could do, what the individual bands met. And interestingly, when we went about 9 months and started to take a look at our data, our ED physician group split fairly evenly among those that used the test versus those that didn't. So it created a really nice case control scenario where we could risk adjust the population and use the patients at the same level of risk of sepsis in order to compare the two groups, because we had half of our physicians that were using it, about half that weren't using it. So when we use the criteria of suspected infection patients, and we compared the tested population to the untested population, among those that were tested, we saw about a 42% reduction in mortality in the tested population compared to the untested population. And I can tell you, in data hot off the press, I literally got last night, after now 18 months of running it, we're still seeing about a 35% difference in mortality, or lower mortality, in those patients that were tested and where the test was used compared to those patients where we didn't use a test. We also wanted to look at hospital length of stay, because with any of these diagnostics, and I forget who said it earlier, besides me, cost matters in these cases. So if we're going to ask our health systems to invest $100, $200, $300 in a sepsis diagnostic test, it better have a meaningful outcome. So one of the meaningful outcomes that we wanted to look at was length of stay. What happens to length of stay when we use the test compared to when we don't use the test? Well, it's about 1.9 days shorter in those populations where we use the test compared to where we didn't use the test. And largely we attribute this to it gives our clinicians confidence in their diagnosis, and it prevents them from continuing to focus on looking at other things. You'll see the same theme come through as we go through another couple of slides. So when we sort the data a little bit further and we say, let's narrow down on patients from that suspected infection population. Let's now look at those that we clinically make a determination these patients have sepsis. What does this do to our mortality rate? Again, we had about 800 patients in each arm. And when we compare the tested population to the untested population, we see about a 35% reduction in mortality when the test is used. Again, attributed to the fact that these patients are getting on the right treatment faster because we have a more accurate diagnosis that leads to that lower levels of mortality. Same population, we see about a 2.2 overall reduction in length of stay. Now, I will tell you, in that data that's hot off the presses that I got last night, we've seen this reduce just a bit, and I largely believe that's reduced a bit because we have also seen that our overall length of stay has dropped across the institution because of some efficiency gains that we've tried to work through. But here's the most interesting piece of data. What about the patients that we say are not septic? So they still came in with suspicion of infection, but we have low risk of sepsis based on the test. Even in this population, where the test is used, we continue to see a reduction in overall mortality. We also continue to see a reduction in length of stay. Now, I don't have for sure data on why we're seeing this, but we think this is likely due to, by ruling sepsis out, it gets us to focus on other things. So you've got this patient that may be presenting in shock, as an example. Instead of focusing on sepsis, we're now thinking about maybe cardiogenic causes of shock or other causes of shock, as opposed to focusing on sepsis. And because we're avoiding diagnostic anchoring, that gives us the opportunity to get to the right diagnosis faster. And again, we're seeing a reduction in length of stay in those populations. I'll emphasize to you guys, this is early data. This is one center. We need more data in these particular areas, but at least it's starting to show some promise for the potential utility of some of these tests. So let's take a look at one of the transcriptomics-based approaches, or the genetic-based tests, and look at its performance. And we'll look at the trivarity test. So the thing I really like about this test is, well, today it's CLIA moderate. This is pretty simple to perform. You literally get a tube of blood, and it doesn't matter if it's contaminated or not, so we don't have to worry about tube contaminations here. You literally take the tube, you put it into the cartridge, and you put it into the instrument. This is CLIA waivable, and this could potentially even be done in those micro hospitals, in those critical access hospitals where we may not have expert microbiologists that are available. So we can run this test fairly easily. Now, this test gives us a bit of a different piece of information. So it's hard to compare these technologies to one another because instead of telling us about risk of sepsis, this particular test gives us two pieces of information. It's going to give us a bacterial risk, a viral risk, so risk of what kind of pathogen may be there, and it's also going to give us an illness severity score risk. Again, I want to point out, illness severity is not the same thing as risk of sepsis. And I can tell you that through some of the early experiences with this test, several patients, they have seen low bacterial scores, low viral scores, high illness severity scores that end up turning out to be this patient is having an MI. So when you look at this kind of a technology, it's important to make that determination of what it's telling you and what it's not telling you. So this test assigns patients into 4 different groups. It gives you very high bacterial, viral, or illness risk, high risk for each, medium risk for each, and then low and very low risk for each. So it gives you the 4 different score groups for each of these particular markers. The advantage of this kind of a technology, it gives you more actionable pieces of information, or at least potentially more actionable pieces of information. It isn't just telling you sepsis versus not sepsis. It's going to tell you, okay, this is a patient that's at risk of severe illness, and this is a likely bacterial infection versus this is a likely viral infection, which can help you to make decisions around whether or not I initiate antibiotics or not, or whether I initiate supportive care or not, or if I have low risk of viral, low risk of bacterial, but high risk of severity, maybe I start doing a workup for cardiogenic shock, MI, other things. So it gives us that advantage of being able to give us a couple of different data points. So this test was evaluated in about a 1,200 specimen study that was conducted at 22 sites across the US. And it was adults presenting to the emergency room with suspected infection, plus 1 abnormal vital sign. You'll notice one of the things as you look at all of the data on these technologies. They're going to give you a lot of negative performance data, and they're going to give you a lot of high performance data, or of rule-out performance data, but they don't give you a whole lot of data in this in-between population. And there's a reason why. Sepsis isn't simple yes or no answers. It's shades of gray. And sometimes you will have these patients that both your clinical gestalt and the test data doesn't give you a definitive answer. So it can oftentimes be seen as a criticism of the analytical performance of these tests that we don't include those middle groups, but that's just the reality of managing sepsis patients. You don't always have a black and white answer. But overall, when you look at both the rule in and rule out data, it's quite good, ranging from 86 to 97%. The advantage of a technology like this is it allows us to kind of untangle some of these challenging questions. It allows us to flag spotting infections early, identify who's having a critical illness early, while avoiding unnecessary admissions, antibiotics, and reducing our length of stay in the ED. I'm curious, and again, show of hands, how many of you guys in the last month have heard that your ED has been boarding patients because they can't process enough patients in the ED? A lot of you have heard that. How many of you guys have heard in the last month your hospital is at capacity and you can't take any more patients? A lot of this group says that. These kinds of technologies have the potential to help us better assess these patients, better make a determination, who can I safely send home together with my clinical gestalt versus who really does need to be in the hospital. There's also significant opportunity for better diagnostic stewardship with these technologies because it allows for the potential reduction in use of blood cultures, reduction in viral panels, again, as a bean counter for most of my day now. This is something I look at all the time. How many viral panels are we sending? And those are expensive because they don't get paid for. As well as potentially reduce things like CT scans, troponin sets, et cetera. So there's potential for diagnostic stewardship in addition to outcome benefits. So Triverity was evaluated by a study published by Rich Rothman and colleagues at the Johns Hopkins University. They enrolled 321 patients in their study, and they had some interesting benefits that they report on. They report on about a 5-hour reduction in time to get antibiotics started. Again, as we look at those core measures of what does CMS measure on our hospitals, it's time to initiation of antibiotics when you have an at-risk sepsis patient. If we can get those antibiotics started potentially 5 hours early in that ED visit, that has a huge benefit in your sepsis core measures. They saw around an 8.7% absolute overall reduction in direct admissions from the ED, a 3-hour reduction in length of stay to the ED, which is gold to an ED physician. Around a half-a-day reduction in hospital length of stay. And again, I want to point out to you here, 35% reduction in readmissions to the hospital, 23% reduction in ED bounce backs at 28 days, and a 50% reduction in clinical microbiology orders in the ED. Some pretty significant outcome benefits attached to that. Again, like our data, I would argue this is somewhat preliminary and it's a single center, but these are fairly encouraging results that we're starting to see. In a multi-center study or in a multi-setting study, and I think this is particularly important because it doesn't just look at an academic medical center, it looks at an impact in an urban country hospital or an urban county hospital. It looks at an impact in a rural health system. So it looks at impacts across multiple different settings of care. Again, they see between a 6 and 10% improvement in direct discharges from the ED. So the patient is seen, cared for, and is safely sent home from the ED without an increase in ED bounce backs. And they also see a significant reduction in the number of test orders. And interestingly, they also saw an increase in troponin orders and ED-related discharges because they're able to rule out MI because of that severity component of the test as a part of one of these studies. So early data showing some potential benefit for this technology as well. They also have looked at antibiotic and diagnostic stewardship related to the tests. They've seen across at least one study around a 20% reduction in blood culture orders, around a 40% reduction in viral panel orders, and around a 30% reduction in antibiotic prescriptions when using the test. Again, around 200 to 300 patients in these studies. We need more, but overall about a $351 cost per testing in antibiotics saved as a result of using this technology. AI is all the rage. There is not a day that goes by that I don't hear something about AI. And by the way, just as a plug for the new Manual of Clinical Microbiology, there's a really exciting new chapter coming out in the 14th version of the Manual of Clinical Microbiology covering AI as it applies to Clin Micro. Should be a barn burner of a chapter, so when it gets published, get your copy. So let's take a look at AI tools for sepsis. Every day, there's a new AI tool that I hear about being described for the diagnosis of sepsis. It's really important as you look at these tools and as you advise your health systems, take a very, very close look at these tools, take a look at how they're being developed, and really look at the vast majority of these are not FDA cleared. To date, how many of you would say that there are more than 10 AI tools that are FDA cleared for sepsis? You guys are 100% right. One tool that is today FDA cleared, one AI tool that is FDA cleared for the diagnosis of sepsis. We'll talk about its performance in just a moment. It's also important to note, just because somebody says, I'm using AI for the diagnosis of sepsis, not all AI is created equal. These tools use varying levels of AI, ranging from expert systems, so think your Vitek, that helps you interpret your susceptibility, so if, then this types of rules. To a lot of these systems use machine learning, and even some of the newer ones are using deep learning where they have deep analytical algorithms that evaluate existing medical record data and make a recommendation on sepsis or not. So understanding what kind of AI is being used, how is that data collected for that AI, is critically important to understanding the performance of these tools. You also have to really clearly understand what is the intended population and where this tool is going to be used, and has it been evaluated in that population. So if the tool has been developed for use in the ED, there is no data to say that it will predict outcomes or predict risk of patient having a bad outcome in the ICU or in the inpatient environment. So you have to really understand what is the population that's used to train that algorithm, And does that population actually look like the population I want to test? Because what we've seen over time is that oftentimes you see data that's collected for these at a single center, and we try to transpose that onto a different population, and we see absolutely no correlation between the two populations. And a little secret is, if you actually dive into these algorithms, the vast majority of the algorithms use a database known as MIC3. How many of you guys have heard of that before? Yeah, I didn't either. MIC3 is a database that was developed from 40,000 ICU patients that presented to Beth Israel Deaconess Medical Center in Boston between 2001 and 2012. They've got a ton of de-identified PHI data, and there are about right around 3,800 sepsis patients or suspected sepsis patients in that database. Most of the developers that have built an AI algorithm to flag sepsis use that database in order to get their training set. Well, the question is, if you're living in rural Wisconsin, how many of your patients look like somebody that lives in Boston and that's potentially presenting to Beth Israel Deaconess Medical Center? And for those of you that may not be familiar with Beth Israel Deaconess Medical Center, this is a large academic institution that's associated with the Harvard hospitals. They do a ton of transplants and high tertiary care levels of care. So how many of my patients actually present like that? How much diversity exists within that population? And can I ultimately take that data and transpose that onto my population? The other key thing to look at is, how is the algorithm developed? So depending on whether it's FDA cleared or whether it's not FDA cleared, can ultimately make a determination of whether that algorithm continues to learn as you use it and continues to adapt as you use it, or if it's a fixed algorithm, meaning that the FDA has said you can learn this far, and anything past here, you have to do a new clinical trial to evaluate its performance on. So if it's not a fixed algorithm and it continues to learn, we've seen examples where we start to see performance degradation over time. And the perfect example of this is the Epic Sepsis algorithm. I'm just curious, because we all live in Wisconsin. How many of you guys use Epic either as your lab information system or as your electronic medical record? Wow, almost everybody in the room. Well, I guarantee you, somebody in your health system has heard about the Epic Sepsis algorithm. You've also probably heard that there was a study published out of the University of California, San Diego, that ultimately showed that the Epic Sepsis algorithm, at least the first version, actually caused harm to patients because it misclassified sepsis patients. They've redone that, and there's now version 2. And even though it's not FDA cleared, I'm going to show you some data on that because I think it's important because, again, nearly everybody has Epic in this room. So let's take a look at a couple of these sepsis algorithms. One of the algorithms I like to take a look at is the sepsis immune score from Prognosis. And I like this to take a look at this because this is currently the only FDA-cleared sepsis algorithm that's available in the United States. It's indication for use as an aid in the risk assessment for the presence or progression of sepsis within 24 hours of being admitted to the ED or the hospital, where sepsis is suspected or a blood culture is ordered. So this uses what's called a random forest model, AI. So this is true AI. It uses 22 different features or 22 different markers in order to feed into the algorithm, but it is a fixed algorithm, meaning it can only change so far per its FDA clearance. So what are the kinds of markers that are included in the Prognosis immunoscore? And you guys will all get these slides because you may not be able to read the graph on the right of the slide. But it includes things like procalcitonin, respiratory rate, systolic blood pressure, platelet count, blood urea nitrogen or BUN, bilirubin, age of the patient, lactate, temperature, as well as sodium and neutrophil counts. It has several components that are mandatory for the AI algorithm to fire, and it has a number of components that are optional that just contribute to improving performance. So the mandatory requirements are your blood pressure, your temperature, your respiratory rate, your heart rate, your oxygen saturation, as well as your platelet count, your BUN, your creatinine, your procalcitonin, and your C-reactive protein. So you have to have all of those values input into the medical record for this to even fire. Everything else is optional in there. And based on whether that component is present or not, it then will be weighted into the algorithm, with some having higher weights versus others. So a white blood cell count tends to have a bit lower weighting, as opposed to the respiratory rate and the procalcitonin tends to have a much higher rating overall in contributing to the algorithm. Overall, the area under the curve of predicting sepsis has reported in a New England Journal of Medicine paper to be about 0.85 in order to predict risk of meeting the sepsis 3 criteria. So the same authors that described this then looked at a number of different morbidity and mortality measures for use of the outcome, or for use of the algorithm. And again, whether the algorithm assigned a low, medium, high, or very high risk, the benefit of the algorithm in a low risk, your transfer to ICU prediction was around 4.7%. 4.7% of that population needed to go to the ICU. So very, very low population. And ultimately, the algorithm was highly accurate in those cases. Looking at, though, at risk prediction of needing to go to the ICU with a high score, it tended to have a little bit more variable levels of performance. In-hospital mortality, again, we would expect that algorithms should get this pretty good. So low score, none of those patients died. High score, very high score, we would expect a lot of those patients to have a bad outcome, and in fact, it predicted that. So we see reasonable overall levels of performance with this algorithm. Again, this is the clinical trial. It's important to note with any clinical trial that these are oftentimes highly curated patients, so we need more data in this particular algorithm as well. The last algorithm that I wanted to mention today, because again, all of us have Epic, and I can guarantee you, if your health system is a bit like mine, our motto is, if Epic offers it and it's okay, we should implement it. So you will probably see pressure to use the Epic sepsis algorithm because you're probably already paying for it, and why pay for another technology when Epic's got one? So the second version of the model uses what's called a gradient boosted tree model. Again, that's a type of AI that's available, and that this would be a machine learning type, so it actually does learn a bit. This is not an FDA cleared algorithm, meaning it does continue to change over time. So following its performance in the literature over time is going to be really important. The paper that I'm showing you here is a 2026 paper, so it was just published, and it was a 4-center evaluation of the Epic sepsis prediction model, V2. It looked at the University of Michigan, Ohio State, Emory, and Metro Health. They overall see an area under the ROC curve of between 0.83 and 0.86, which again is fairly reasonable levels of overall performance when they look at it. And if we look at a comparison of the performance of the Epic Sepsis 2 versus the Epic Sepsis 1 module, the good thing is, at least in 2026 data, we see actually much better outcome. So Sepsis 3 prediction, overall at Michigan, at Ohio State, at Emory, and at Metro Health, we see a significant improvement in the area under the ROC curve, or the overall performance at each of these health systems. But we again see variation in performance of the algorithm. At Michigan, even the new algorithm was about 80% sensitive, versus at Metro Health or at Emory, which probably more closely mimicked the population that was used to train the algorithm, we see closer to about 90% performance. If we look at before clinical recognition, so before the doc said, this is a sepsis patient, we see major improvements in Epic Sepsis 1 versus in Epic Sepsis 2 versus Epic Sepsis 1. Again, at Michigan, we see a fairly broad separation between the performance of the two algorithms. but it's still about 80% performance. Emory and Metro Health tended to have a bit higher overall levels of performance, about 90% recognition of sepsis. So we're seeing improvement in this. Again, this is very early data. We need more data before I expect we're going to see wider utilization of this particular algorithm. So what's our summary? So our summary is sepsis has long suffered from ineffective tools. I hope I've convinced you today that we need better tools in the diagnosis of sepsis. I hope I've also convinced you that while microbiology is incredibly important in sepsis care, sepsis is not bacteremia. And we can't use just improvements in blood culture to solve this whole answer. Tools like the host response can help identify suspected sepsis patients earlier, can help us better direct our clinical workup, and can help us be more effective in the emergency room. Early data from each of the examples that I cited to you today has shown considerable utility. Again, this is early data. We need more data. We need more data in different populations and in different care settings. But these may be very useful tools to help us risk assess patients. Data on one test from our institution would show that using a host response test has resulted both in a reduction in length of stay and an improvement in mortality. And it's important to note there are numerous options. We have examples of transcriptomics, we have examples of physical cell profiling, and we have examples of AI that may be able to help us better diagnose sepsis patients. And I would consider you, as laboratorians, to actively be involved in this. Oftentimes you will see these arguments being made to the C-suite, these arguments being made to the ED, and they skip coming to the laboratory altogether. Laboratory's input on this is critical. Your voice is critical to making these decisions on what fits in our health system, what can offer our patients the most benefit. This needs to be a multidisciplinary approach. Thank you so much for your attention today, and I'm happy to take any questions anybody has.
Hi, I'm Brianna from Ledeboer at the Ascension Hospitals. So a couple of years ago, Ascension got rid of our procalcitonin testing, saying that it wasn't utilized appropriately. So I'm curious, with your IntelliSep, is that something that is a single test orderable? Is it something that needs to be done serially?
So this is a great question.
Thank
It's
you.
a test that really, it's a test that's currently approved for using singly. And we've seen IntelliSep, we've seen MDW, we've seen Septicite, and we've seen Triverity all be cleared for a single-use measurement. The key question is, what patients should you be doing it on, and how broad do you want to go with these patients? Because there's huge cost implications to this. So we've been allowing this to be somewhat of an ED physician determination, whether they want to use it or whether they don't want to use it. We're seeing that if we look at that in the context of our broader sepsis population, we're seeing it used in about a third to half of the population it should be used in. So we've actually got a pilot right now that we're about a month into, where we're saying anytime somebody orders a lactate, you're going to get this IntelliSep result, because we're still in the pilot phase right now and there's no cost implication to that. When we get to real costs on it, we're going to have to rethink that, because you're talking about $2 million a year for just our health system for that cost difference. So we'll have some more data on that in the next couple months, but my suspicion is the broader you use it, the better the outcome benefits attached to it. But there's also real cost implications on that, and that will have an impact on the business case around using it or not. But it should be a single use and go. But it is a question that remains also to be seen, whether these tests can be used to predict improvement as a result of interventions. I think it's an open question that we need better answers to yet. I can tell you of the 3 manufacturers that I've talked to, so Inflamatics, Cytovale, and Immune Express, they've all said they want to look at that question, they want to do the research on it, but we don't have any data yet on it.
Thank you.
Thank you.
Any other questions? Yes.
Other than more rapid administration of antibiotics, what other kind of therapies would they initiate based off of like the Intellecept to reduce those mortality rates and like the stays and stuff?
So oftentimes it may be volumetric care, so supporting volume care. You may be talking about using vasopressors or not. Instead of maybe using one vasopressor, you may go to two vasopressors. Antibiotics, again, as you had mentioned, ICU level of care is important. All of those would be important potential interventions in those cases.
And was there any data, I'm just thinking of, of our health system where it might not be available at some of our, or many of our health systems, where something like this might not be available at our more rural hospitals. Was there any data on like timing of test result versus outcome? Obviously at Freighter, you got it in real time.
Yep.
But if you got the result, if you ended up having it to send it somewhere stat, if it was delayed by 4 hours, is there any data on that yet?
So the feedback from the ED is they really need this in the under 30-minute time frame, because that's when they're making all of their clinical decisions around interventions. So this really does need to be something that's done locally, as close to the patient as possible. And Tim, you point out a really good, really important characteristic that folks need to look at when evaluating these tests. So the Intellecept for us is a fairly big instrument. So you're talking about an instrument that's probably going to take up about this much bench space, and you have an initial 8-minute step on the instrument, then you have to take a component off and put it into a reader. You really need a laboratorian to run that, which means that if you are trying to support a location that may not have 24-hour laboratory service, maybe a lower volume, that test may not be as good of a fit. By contrast, like the MDW test can be done on a hematology analyzer. So if you use Beckman hematology, MDW may be an option that you want to think about. If you want something that's closer to being CLIA waived, something like Triverity may be something you want to look at, because that can really be done by anybody, because there's no manipulation that's required. Goes on the instrument does everything, and then when it's done, you throw away the cartridge. So it's a really important consideration to workflow in terms of what your location is, what you can support, what your volume is, and to which tests I'm going to choose. It also depends on, if I give these pieces of information to my emergency physician group, are they actually going to know what to do with it, and do they have the tools available to them to make meaningful use of that data? And so having that decision support that may be there to help them in making that decision is also a critical component. So this is not with any of these tests, this is not a simple, I'm making this test available, go use it thing. One of the key things that we've really learned is there's a lot of education, there's a lot of physician nurse feedback that needs to take place as you're implementing this, so folks really get comfortable with it, they understand the results that they're going to get, and they can act on those results.
All right, we have time for one more question.
I'm curious if we know whether any of the developers of the new AI products are starting to include some of the other two elements in their algorithms.
So great question, not yet. These are all fairly early in development, so I think we'll probably see some of that happen over time. Each of the systems, or at least the Septisite, the Intellecept, and the Triverity, have a certain amount of AI in it themselves to help them interpret the result, but I suspect we will probably see a confabulation of these that kind of come together over time. And as these get more broadly used, we'll see them incorporated. It's also important, a lot of the AI algorithms that are being developed, many of them are, there may be some value in having an algorithm that assesses progression, for example, where it may be used in the inpatient environment, and then one of these values could be very useful to kind of help you baseline a patient. So depending on what the intended use of the AI application is, in addition to kind of what's incorporated into it, I do suspect we'll probably see that over time. Today, though, we're so early in a lot of these approaches that we just don't know whether they're going to catch on or not yet. Because I will tell you, it is not a cheap proposition. You're looking at again, just looking at kind of our hospitals that have laboratories in them, we're looking at about 2.6 million a year in cost for a program like this. Again, if we really see a lot of these outcome data and we can reduce mortality, that's an easy argument to make, but it is going to slow some of the adoption on these.
Fantastic talk. Thanks, Nate.
Thank you so much for having me.